how sustainable the moves were on the dance floor, and some of the food. Some of you were packing heavy meat, so I was concerned not enough vegetables. We're looking at balance here amid the overarching framework of the Sustainable Development Goals. The session this morning is entitled Old Enemies, meaning HIV, TB, malaria, New Threats, Non-Communicable Diseases, Urbanization, and Climate Change. So we're going to be reflecting on the double disease burden and the role that epidemiological, demographic, and socio-economic changes play as determinants of health in Africa. Now, there's some good news and some bad news, if I can put it crudely. The good news first, as far as communicable diseases, so we talk about the big ones, HIV, TB, and malaria, are concerned, the disability-adjusted life years, so the sum of potential life years lost due to premature mortality or productive life years lost due to disability, decreased from 532 million in 2000, remember the Millennium Development Goals, to 390 million in 2015. 390 million too many, but it's a significant reduction. There's a lot to do, though. Now for the bad news. In 2015, non-communicable diseases, including cardiovascular disease, cancer, chronic respiratory disease, and diabetes, contributed 28% of total disability-adjusted life years. That's up from 18% in 2000. So what's really going on? What is happening to African health? So drawing on their vast experiences in different parts of the world and different fields, our panelists are going to chew on this. They're going to share their knowledge and try and help inspire African-led action to address these challenges. So let me start by introducing the panel formally. First, on my immediate left, is Ambassador Macharia Kamau. Ambassador Kamau has served 24 and rising years at the United Nations. He's a two-time UNICEF representative in the Caribbean and Africa, a two-time resident coordinator, I think that's with the UNDP, in Botswana and here in Rwanda, two-time ambassador in Nairobi and now in New York. He's also worked for the Bill and Melinda Gates Foundation. Next to him is Professor Jean-Claude Mbanya. Professor Mbanya teaches medicine and endocrinology at the Faculty of Medicine and Biomedical Sciences at the University of Yaoundé in Cameroon. Professor is also a consultant physician, a director of the Health in Transition Research Group, director of the National Obesity Center, University of Yaoundé, and chief of the Endocrinology and Metabolic Diseases Unit at the Hospital Central in Yaoundé. He's got a lot of experience, and he and I were joking earlier. He is the man who's got his finger on the pulse and the heartbeat of African health. So we expect much from him during the session. And next, our host, the mayor of Kigali, Mr. Pascal Nyamurinda. Now, the mayor was elected only recently by city councillors in February this year, and prior to his election, Mr. Nyamurinda served as the Director General of the National Identification Agency from 2012 to 2017. He was also a member of the Permanent Mission of Rwanda to the United Nations in New York for 5 years. Our fourth panelist is the Honorable Dr. Mohamed Anwar Husnu, the Minister of Health and Quality of Life. Not just Minister of Health, Minister of Health and Quality of Life. You see, they bound them together. It's integrated and hopefully sustainable. Yes, this is in Mauritius. Dr. Husnu is a qualified pediatrician who practiced in various hospitals in the UK. Before returning to Mauritius in 1982, he returned. He's a returnee. They called, and he answered, yes, he's a returnee. That's right. Excellent. So we move finally, on the far left, to Professor Michael Marmot. Professor Marmot is a professor of epidemiology and director of the Institute for Health Equity at University College London. He's also the immediate past president of the World Medical Association and author of The Health Gap, The Challenge of an Unequal World, and Status Syndrome, How Your Place on the Social Gradient Directly Affects Your Health. Ladies and gentlemen, your panel, please give them a round of applause. I know, women, it's a manel. There are no women on the panel. However, I'm going to address that balance. Yes, I know, by making the contributions from our colleagues here, very heavily female XX dominated. These XYs will have nothing to say. XX dominated. These XYs, they were vamoose. We're going to start, though, with Ambassador Kamau. Many of you will know the ambassador chaired the Open Working Group. It's a long 2 years or so of blood, sweat, toil, and tears, late nights in the UN building and maybe in some of the restaurants in Manhattan, I'm not quite sure. But this group produced the 17 SDGs, including the famous SDG 3 on health. So, Ambassador, let's try and frame this discussion. When people talk about the global goals, they tend to think about sustainability and climate change. But we're really focusing on health. So how do you see the intersection between these global goals and climate change and all the adaptation governments are being asked to do and our agenda today? Better, healthier, productive lives.
Well, thank you very much. It's good to be here. It's good to be back in Kigali, back in Rwanda. You say there are no females on the panel, but I can assure you there's at least one feminist. So
at least two.
You have nothing to worry about. And I am sure there are others. First of all, let me just say how happy I am to be having this conversation. It's really amazing that here we are, 2 years after what was the most complex, the longest international debate and negotiation to put together the Sustainable Development Goals. And we actually believed at some point in 2012 that we were not going to succeed. By 2013, we had serious doubts that we were going to get the new agenda that we now enjoy that is guiding our work in the world. So when I first heard about these old enemies, I wasn't sure what we were talking about, whether we were talking about diseases or whether we were talking about the status quo. Because the biggest challenge that we were faced in putting together the Sustainable Development Goals was not the old enemies of the diseases themselves as such. It was the old attitudes, the old narratives, somebody said a little earlier, the old paradigms, the old thinking that have become so dominant in the world and that drives the way in which we do business, and we have done business for years. You know, we are in Kigali, yeah? We're in Rwanda. If there is a country on this continent that has truly demonstrated that all paradigms and all narratives have no place in transforming people's opportunities, it is Rwanda. And this is why I truly believe that the SDGs, now that they've come into their own, and I want to congratulate WHO for taking on this challenge, because there is a lot of resistance. There was a lot of resistance, and I believe there still is a lot of resistance to the Sustainable Development Goals. That's the first thing. The second thing is to recognize that one of the biggest outcomes of this debate was the goal itself. It seemed to be too audacious, just too overambitious. And those people who really were very comfortable with the status quo and the old ways of doing business felt truly uncomfortable and unwilling to move forward with a goal that they felt would not be achieved, could not possibly be successful. How do you bring health to all people everywhere? The targets were truly audacious. We're talking about ending newborn deaths in 15 years. You're talking about ending HIV and AIDS, ending TB, this was people are just unable to process this. But here we are today, doing this, beginning the journey, seizing the opportunity, and running with it. So my initial comment this morning is to congratulate each and every one of those people in this room and out there who believe that the SDGs can be implemented, who recognize that health isn't just about the medical and clinical practitioners, that health is about everything that's contained in all the 17 goals of the SDGs, because it is only through implementing all the 17 goals that we shall be able to achieve all of the 13 indicators, targets, including this one. This is 13.8. We have to, which we are trying to implement, the one on universal health coverage.
Absolutely.
So this is a very important, very encouraging moment for me.
Fantastic. But we've got the overarching, I suppose you could call it a spectre of climate change and the burden of adaptation, which many countries are facing. And I'm just wondering whether you are worried that this goal, number 3, could be derailed by the advance of climate change, by the rapid urbanization, by some of the things that a lot of people feel are beyond their control.
First of all, let's recognize that if history has any lessons, nothing is beyond the control of the genius of the human mind. We can apply ourselves in very special ways to achieve anything we want. We just have to believe it. Some of you may also know that I was the special envoy of the Secretary General last year on El Nino and climate change. And I went literally around the world trying to deal and trying to bring awareness to this issue of climate change and the impacts of weather events around the world. There is no question that we are in a cycle of more intense, more ferocious weather events around the world. And they're going to become a common feature in our lives. So the first message is that get used to it. Climate change is here to stay and is going to intensify. With that is going to come real risks. There are countries that are going to suffer huge droughts. We've seen it in the Horn of Africa, Southern Africa. That is going to have real consequences in people's lives, including health. There are countries where the climate is changing and different kind of diseases are beginning to reemerge where they weren't. Waterborne diseases in places that are becoming waterlogged, or in places that, so we are having real consequences that are driven by climatic events, their frequency, and the inability of communities and societies and cities to cope with these changes. So the short answer to your question is yes, climate is a serious threat to people's health moving forward.
Ambassador, thank you very much. Let me move to your left to Professor Mbanya. As a clinician, I'm just wondering then how you embrace this challenge, given the position of particular diseases, the prevalence in Cameroon, and then, of course, looking more widely across the continent. What do you think the priorities are at this particular point?
Yeah, thank you very much for inviting me here. The topic, especially the title of our session, is very intriguing. It talks about all enemies. I know that medical science has transformed communicable disease, most of them like HIV/AIDS, to chronic diseases. So we're actually new friends, so that was good. But more so, I think one of the fundamental problems we have in tackling the non-communicable diseases, and I don't want to develop about the burden and all the mortality and morbidity, it is this leadership at international level, which we are having now, at leadership at the regional level. And I think I would deal very much with the regional level. WHO recently promulgated 86 best buys, 16 good buys. And I think that WHO African region in its leadership position should be able to differentiate and define the African must buys so that most countries can fulfill their obligations in the management and in the control of non-communicable diseases. But then there is the country, and you asked a very good question about my own country and other countries. I think the example I want to use is one of political will. And in this political will must be engaging. I know of a president in one East African country who went to one of the large city hospitals, just visiting impromptu, and realized that there were so many patients sleeping on the bed. And that gentleman canceled one National Day celebration and bought beds for all the hospital. And that is the sort of political leadership that I'm talking about. But even when you have the political leadership, in terms of NCDs, you need a multi-sectoral approach, all of government approach. And these approaches such that we can be able to really, as we are doing at this session, integrating mayor, the city, the minister, politicians, in order to combat these diseases. Particularly in Africa, Mr. Moderator, we have a lot to do. And in fact, this lot has to do with implementation of good national programs. We don't have programs. How can you be able to solve these diseases, prevent them without implementing good programs? If you ask the WHO, they'll tell you that so many people have programs but which are put and decorated in their cupboards. So whenever a foreigner comes, then they will remove the program. But in terms of what they actually do with the programs, there is nothing. And I want to talk about support. In fact, you have to be able to gather information and information technology. And these are what you use to assess either the healthcare system or what you are doing in terms of a national intervention. And this is where we are very weak, especially in Africa. We still have this communicable disease-oriented healthcare system. So much so that when a patient comes to the hospital with malaria, what you do is that you see them with obese and other risk factors for non-communicable diseases. You send them home, and 2 months later, they die from a stroke. So we have to change the paradigm. We have to be able to treat the patient and not the disease, as we are doing right now. And again, this two-tier healthcare system. In my hospital in Cameroon, if you have HIV, AIDS, malaria, TB, you are given all the drugs. You go and they even beg for you to come and be followed up. But if you have things like diabetes or cardiovascular disease, you are left to yourself. If you cannot take care of it, the family has to, or you will die. Why? Some of my patients, one of my male patients asked me, "Professor, why is it that I didn't have HIV/AIDS?" And I said, "Why?" He said, "Because in diabetes, I take care of everything. With HIV/AIDS, we do everything." And then there's essential access to essential medicine. I think it's a myth. We all know that we talk about access to essential medicine, when in terms of procurement, we don't even have a tender system. Why can what is very prominent in Africa with subsection, ECOWAS, all this, East Africa, why can they not make a general tender for essential medicines and be able to afford, get it cheap and affordable? And of course, I want to stress on what we are really failing at, that is national demographic surveys. How can you do health planning without knowing the number of patients, without knowing the equipment you need, without knowing the necessities? What we have to do in order to get periodic national sufficient competence is essential if we have to combat non-communicable diseases.
Professor Mbanye, thank you very much. So far, we've heard from a diplomat who helped to create the framework for the discussions we're having today. We'd heard from a clinician. Oh, what a litany of woe, Professor, you gave us there, but also some ways out. There were some tools that you think we can use that are at our disposal, but that require political will. This is something that's been hanging around in this room since yesterday. People talk about political will. So let's go to a politician, a city mayor, the mayor of this beautiful city of Kigali. Let's find out what they're doing to try and implement some of the things that people have been recommending here, because you're very keen, Mayor Nimurinda, on establishing a healthy city here in Kigali. Explain what you're doing, what your targets are, and how you're trying to implement them.
Thank you very much, Mr. Henry. First of all, I wish to express my appreciation to the HWO for having chosen the city of Kigali for this important forum. Thank you so much, everyone, and I hope that Kigali city is treating you kind. Welcome to this beautiful city. To understand the Rwandan experience, we first of all have to understand where we come from. And one of the experience in this city and the country in general is the leadership. In '94, during the genocide, this country was completely destroyed. Everything was destroyed. and we needed, after the genocide, a visionary leadership under the RPF and its president, His Excellency, the President of the Republic, Paul Kagame. And to start to build this country was a big, big challenge, and that is where everything was to be rebuilt from nothing. Actually, we had to build everything from nothing. And one of the initiatives that started after the genocide was to change the laws. And one of the laws that helped to clean the city, to match the public safety and the public health, was to renew some laws to enforce the community work. And the community work that which call all the population, the citizen of this city, to do works, community works, every end of the month, to clean the city, and the population to clean their homes, and their vicinities. That is a big initiative, in which until now continue in the whole city, in the whole country, to clean and to make sure that all the environment is cleaned. We plant trees, we make reforestation, we make our city clean. Another initiative that was initiated under the government and working also with different stakeholders, government institutions, was the collection of garbage, organized within all decentralized entities. All the sectors of the villages, they organize the collection of garbage and where the garbage, and they bring them to the sanitary landfill. Also, as a matter of fact, every sector, with the consent of the population, we have bought a car that is used for the safety, public safety, but also for the public health, for the cleanliness and for their security. Another thing that is very important is the healthcare scheme, which have been initiated by the government and the Ministry of Health and the local authorities. And the local authorities mobilize people. They make public awareness so that everyone has that universal health insurance. As a matter of fact, today in the city of Kigali, we have people have reached the 98% in Kigali city, 98%, and we have even one cell which have paid their contribution for next year.
Mayor Nimurinda, let me ask you this, because a lot of Africans from around the continent, they look at Rwanda and they say, how have they been able to do this? I mean, I'm from the west of the continent, so from Ghana, many of my friends are from Nigeria, Sierra Leone, and they say, if you ask our Nigerians or our Ghanaians to do something, they won't do it, they will just refuse. Why are these Rwandans, when you tell them to do something, they do it? You see Rwandans jogging at 5 in the morning, or cycling, and you even have Mille Collines. You have 1,000 hills, and they are cycling up these hills, healthily. Now, how are you getting this message across? How are people imbibing it? Because it's working here, but in some places people maybe are more resistant. So what are you doing with the messaging?
With what? With what? Oh, yes, actually, first of all, we have a legal framework. That is one for all these initiatives.
But it can't be the law that you must get up and jog at 5 in the morning. People are doing it because they feel, I'm from Kigali, I want to be healthy.
Yes, actually, that is a big initiative that has been taken within the Kigali city, but also just to mobilize people. Actually, it is a change of mindset. The mindset have changed because after the genocide, we thought that everything has to be changed because we have many challenges, and from those challenges, we got the strength to change a lot of things around the health of the city. As a matter of fact, for example, we were wondering how this city, the roads, the tarmac is brown, for example. That is a small experience, but how do you have this tarmac brown? It was because there was no definition of the road, for example. But under the government initiative, we defined what is the road. The road is where the space for cars, a space for pedestrians, and a space for water, for the drainage. And that's where you see, for example, this city is clean. You have those three components of the road. And another thing that is very important here in this city, you will see that you not see people smoking in the road, because we also have, under the leadership of Ministry of Health, banned or sensitize people not to smoke. And if I see, for example, someone smoking in a restaurant, I will.
He's hesitating.
Actually,
what will you do, Mayor?
I wanted to say that at 80%, I can say that is not Rwandan.
All right.
Smoking in a restaurant or in a public space. So
all right, Mayor, thank you. Thank you very much. I'm going to let you end there. So I've just been looking at the life expectancy of some of the countries represented on the stage. So in Cameroon, it's around 58. We don't know how many of those years are healthy, but 58. And it's influenced by lots of different factors, of course. Ambassador, I'm not sure about Kenya. You can probably tell me what the life expectancy of the average Kenyan is.
I think it's about 60...
60-something?
63.
63? All right. In Rwanda, across the whole country, over the last 10 years, it's gone up from, this is aggregated between male and female, from 51 to 64.5 years, and it's increasing all the time. And then we're going to move to Mauritius. Life expectancy currently 74. And Honorable Minister Husnu is smiling happily, pleased, but I can give you some other statistics that will not make you smile. 53 million liters of alcohol per year. 53 million for a population of how many? 1 point? Right, I think we need to put on the microphone and we need to address some of these things, Minister. We need to address some of these things. So we've heard from the Mayor of Kigali. Please give us your expertise and experience of Minister of Health and Quality of Life in Mauritius. The good and best practices in implementing non-communicable disease prevention and control interventions in your country, because you are always at the top of these indices of human life, quality of life, but you have some very serious challenges, haven't you?
Thank you, Chair. I mean, in Mauritius, firstly, as far as the communicable disease is concerned, like HIV, it's not much of a problem for us. We have about, for a population of 1.2 million people, we have about 10,000 people suffering from HIV. It's not a major problem. But our major problem in Mauritius is non-communicable disease. Well, I'm just going to stick to the four main ones: cardiovascular disease, cancer, diabetes, and chronic respiratory disease. Just to give you an idea, 80% of death in Mauritius are due to non-communicable disease. 80%. And just to give you an idea, again, I'm going to give you some statistics. Diabetes, in the latest survey we did in 2015, diabetes, the prevalence of diabetes was 22.8%. The prevalence of pre-diabetes, 19.6%. So if you add these two, makes you roughly 42% of the population are at risk of complication of diabetes. That's number one. Hypertension, prevalence of hypertension in Mauritius, 28%. Very high. Nearly 42. Diabetes, hypertension, 28%. Smoking, 19%. Alcohol, you mentioned, about 53%. And how many people do exercise? When we exercise 30 minutes every day, only 23% of the population do exercise, which means 76% of the population does not do regular exercise. That's our problem. That's our problem. But anyway, we have sit down. We have tried to work on it over the last few years. We have been doing lots of it for the last few years. Maybe gradually, maybe later, I'll come back and discuss how we have been working on these issues. But our major problem, NCD, is real epidemic proportion in Mauritius. But we are trying to find solution. We are working on it.
Thank you very much indeed for giving us your perspective, Honourable Minister. Let's finish off in this round with Professor Marmot. You've got a lot of experience in this area, and you've written about determinants, particularly social determinants, which can affect somebody's lifestyle and healthcare. What do you make of what you've heard, and what do you think governments, both at a national level, regional, or even city level, need to be doing to try and achieve this goal of universal healthcare, particularly when we frame everything with those global goals that we want to try and achieve, and Ambassador Kamal is nodding here, by 2030?
Two things to start off. The first is to remind you that on the cover of the report of the Commission on Social Determinants of Health, we said social injustice is killing on a grand scale. That social injustice is acting at a supranational level. Reading recently, a net outflow from Africa of $40 billion a year to the rich countries. Africa is helping the rich countries financially, which is very welcome to the rich countries, but not so good for the continent of Africa. So the injustice can be happening at a supranational level, or, as the Mayor said, going back to 1994, the gross injustice can be happening at a national level and is continuing to happen, not in as extreme a way as in the genocide in Rwanda, but the growing gap between rich and poor. The second thing to say is we want health, not just health coverage for everyone. And that's why it's a privilege to sit on the same platform as the Ambassador, who co-led the Open Working Group on the Sustainable Development Goals, because I've been talking about social determinants of health, and the SDGs give us a mechanism. Yesterday morning, Tim Evans talked about why, in his brilliant presentation, why universal health coverage is a good investment. But let's look at the 5 things that he mentioned. Good nutrition. That's a social determinant of health. That's not just delivered by the healthcare system. That's a national priority, or at least should be. Second, he talked about family planning. Everybody in this room knows that the best single thing you can do for family planning is empowering women. And to empower women, that means investing in early child development, investing in education, and providing occupational opportunities. We're going to hear this afternoon about initiatives for adolescents, and particularly for adolescent girls, absolutely vital, not just a healthcare issue, but a vital health issue. The third one was on health, on curbing epidemics. Where do epidemics happen? You remember Amartya Sen wrote a groundbreaking book on famines, and he said that famines weren't simply the result of lack of food. They were a lack of social organization. Where do epidemics happen? Where poor governance is rampant. And we saw with the Ebola outbreak that well-governed countries could control it, poorly governed countries could not control it. A social determinant of health. Decent jobs. Yes, employing people in the health sector does give decent jobs, but we also know that in many African countries where the vast majority, particularly of women, are employed in the informal sector, that equates to poor quality work, which damages health. The fifth one was eliminating poverty. Yes, health can be a cause of poverty, but so dramatically can poverty be a cause of ill health. To give you a practical example, to make it very practical, when I go to Brazil, the first thing the public health people tell me is not about delivering health care. It's about conditional cash transfer programs to relieve poverty. And what we see in Brazil, the typical social gradient in stunting in the first year of life, low growth in the first year of life, the lower the wealth quintile, the higher the proportion of children stunted. As a result of poverty reduction in Brazil, they have flattened the social gradient in stunting in the first year of life. We've got good examples from around the world where taking practical action on the social determinants of health can deliver not just health coverage to people, but health to everyone.
Round of applause, please. Okay, so that concludes our first round of questions from me. We've got just about a half an hour before we break for our early lunch, and I want to try and get as many of your thoughts, your responses as possible. Look who we have, the talent we have on this panel. A leading diplomat, 2 professors, clinicians, a minister who's also a clinician, excellent, and we have a city mayor who's leading transformational change in this fair city of Mille-Collines. So, I want some excellent contributions from you, particularly those of you who carry XX and not XY chromosomes, even though we have a male feminist on the panel. So please, no men allowed for now. I want the women to come forward, because as the professor said, we know what is required to make transformational changes, particularly the empowerment of women at the grassroots level and beyond. Now, those who don't carry an official function yet, not yet, those people who are... No, you're male, you have XY. So please put your hand down. Men not allowed. A man, no, please, hand down. We have Madame from Chad, a minister, honorable minister from Chad. So please, give me 1 second. Peut-être en français, mes oreilles sont un peu âgées aujourd'hui, donc il faut que j'ai de l'aide ici, avec l'interprète. Madame, c'est à vous. Okay, you want to use the microphone, le micro? Oui, okay. Can we use the microphone, please? Is it working? Can we get a microphone that works, please? Yes. Honourable Minister, merci beaucoup. Thank you very much indeed. Thank you very much indeed. Okay, I want another contribution. Yes, Mary, who spoke so eloquently and powerfully yesterday. Thank you very much indeed for that question. I'm going to go to Professor Mbanya there. Commercial organizations see Africa as virgin territory. They see the middle class growing, and they think these people have money and we have products we want them to buy, especially sugary products or tobacco-based products. So what do you think you should be doing about that?
I think the first thing is legislation, because these are poisons to our children, and this is what is going to bring the next generation down, and they'll be developing non-communicable diseases. And Africa should not be used as a dumping ground. Earlier on, we were talking about partnerships and cooperation, especially with industry. When it comes to non-communicable diseases, we have to put a tick or not, because some of these industries are drivers of the risk factors for non-communicable diseases, be it tobacco, alcohol, or unhealthy diets. So we have to be very careful, and each country has to give legislation. And that's why I thank the Minister of Mauritius, because in Mauritius, they have tried to stamp out that except for alcohol, and you understand why alcohol, is a very limited society. They need to do something to keep sane. So what happens, therefore, is especially banning in terms of the cooking oil, putting caloric values and food values and food labeling. I think this entails legislation, and each African country should bring in legislation to control those determinants.
Thank you very much indeed.
Mr. Chair, if you don't mind, can
yes,
I
okay.
Just to answer that question, what we have been doing in Mauritius is basically on the legislative and fiscal measures. Number one, as we say, cardiovascular disease was contributing about 30% to the death rate. So to control the fat, the saturated fatty acid, we control the palm oil in the oil that people are using every day. That is legislative measures. Tobacco, we control tobacco as well. The FCTC, all the 6 strategies in the FCTC, we applied it in Mauritius as well. Passed a law in 2008, and we are applying it as well. For alcohol as well, prohibition on advertisement, sponsorship, restriction of sale to minors and all that. We're doing it as well. We have the sin tax. Increase in tax on cigarette and alcohol each and every year in the budget is like a ritual. We increase by 5 or 10% every year.
But Honourable Minister, is it having an impact?
It is working. I'll come back to that afterwards later on. And even in school, in the sugar, we are trying to control it as well. We ban selling of soft drink and unhealthy snack in the school, because that's the population you want to get, the young people growing up. That's where you can have the change. So we are putting all these measures to help to combat all this problem.
Excellent. Professor Mahmoud, do you think that's the way African countries are going to have to go, get a bit more draconian on some of these products? Because everyone's talking about globalization and free trade, lower your barriers, allow the big companies to come in. But are you saying people need to vigorously and rigorously protect their populations in this way?
I don't have any doubt at all about it, because we have done it in Mauritius and we have got the result.
Thank you, Professor Mahmoud.
I would never use a word like draconian when talking about people's
Okay,
health.
tough. Robust.
Let's take obesity, which is a major risk factor for diabetes and for cardiovascular disease. what we have seen is in low-income countries, the richer you get, the more overweight and obese you get. In high-income countries, the poorer you are, the more obese. So there's this shift. So then the question is, what can you do to break the link between getting richer and getting fatter and getting more diabetes? And the answer, the evidence is very clear: education. When we studied in Egypt, for example, we found, particularly among women, that as family income went up, women were more likely to be overweight and obese, and diabetes follows that. But that pattern was not true among those with more education. So the secret is doing all the things we just heard about in Mauritius, but getting a more educated population so you don't get that social gradient. And we used to think, for example, take smoking. We used to think that in low-income countries, the poorer you were, the less likely you were to smoke. In India now, what we see, the poorer you are, the more likely you are to smoke. We need to take action on smoking at a national level, but we also need to take action on education to break that link between being low status and being at higher risk.
Okay, thank you very much. Let's get another question. Lady over there. Well, there's two ladies. Lady in the blue and also lady in the patterned. No. C'est un homme. No. Madame, yes. Okay, Madame there and then Madame there.
Hello. Can you
Hello.
hear me? Great. Before I ask my question, I would like to start by congratulating Togo for being the first country in sub-Saharan Africa to eliminate elephantiasis as a public health problem. So Togo is really to be congratulated for this achievement. So we're talking about universal health coverage. We're talking about leaving no one behind. And yet I've not heard a single thing about neglected tropical diseases, which affect over 1 billion people, the bulk of whom live in Africa. We're talking about public-private partnerships, and yet we have a huge drug donation program, which was recently awarded a Guinness World Record, and we cannot get the resources on the table to donate these drugs. So I would like to hear the perspective from the panel about where this sits on the list of priorities for Africa.
Thank you very much. And then lady next to you, well, just further along in the blue, yes.
Yeah, thank you. My name's Rose. I'm from here at Kigali, beautiful city. I've heard all the presenters are talking about NCDs. And even HIV is becoming NCD. Because if you take properly the medicine, you have life expectation like other people who are having NCDs. So I was wondering, they are talking about universal coverage, they are talking about on health, but I haven't heard about palliative care. And I know it's...
Sorry, I didn't hear you. You haven't heard about...
them talking about palliative care. Because the NCDs... palliative care is a medical care which supports people with life-threatening diseases like NCDs. The World Health Organization, in fact, they had that resolution in 2014. And from that time, there is nothing going on, which shows that they are doing what they are supposed to do.
All right.
And I hope from this meeting, we have another Kigali resolution that we are going to do something on palliative care. Because there are no funds in it. We are talking about private partnership, public-private partnership. We should be encouraging even for people to do so. So thank you very much.
Thank you very much. Okay.
There is a question you ask our mayor about why people do community at the end of the month. We have even a car-free day every month. where people go, there is no cars moving, and people do
I've
exercise.
heard about this. And
but then
yes.
you have a problem.
I'm going to have to stop you because we
Yes.
haven't got much time and more people want to ask questions. But thank you very much for your excellent contribution. So let's look at the palliative care. Professor Mbanya, what say you about that? Because she's right. It's something that doesn't come up, but it's going to be increasingly important.
Yeah, I think she's right about it, but it was difficult to answer all the questions. But when you look at restructuring of the healthcare system, be it at the primary, secondary, or tertiary level, one of it, and then with appropriate technology, then palliative care, especially for people with cancers, she did not mention cancers especially, would fit into that model. So restructuring of the African healthcare service, the country healthcare service, to integrate most of what you've talked about is very important. But again, we're limited with funding, and we have to be able to look at imaginative ways of financing for most of what we want to do.
But we also had a question about neglected tropical diseases. Very, very important disease burden. Do you have anything to say about that,
Yeah,
Professor?
in fact, you can name all the diseases in the world. We have to start somewhere. And neglected tropical diseases is one of the things that WHO is looking into it. And there are various areas. So you talk about TB. I come from the diabetes world. TB and diabetes are like two cousins, especially when you are managing them. So there are a lot of things we can bring into the package, but we have to start somewhere, and we are starting somewhere with what we are doing right now. And progressively would add on, and even with syntax, as you heard about it, we need to integrate things, and we also need to be able to train people in order to administer those services, even palliative care.
Thank you very much, Professor. We have the Deputy Health Minister from Sierra Leone. What would you like to say, Honourable Minister?
Will not be upset when you go home, because I'm appealing to the women to think about what you're saving when you cut down on the meat that you cook for your husband and children, the kidney problem. Don't cook too much shrimp, cholesterol. We want some of this to end. We can start in our kitchens. So women do have a role to play outside medicine in helping to build a healthier African nation. I know African men and women always think food is better with lots of meat and whatnot, intestines. Fish is a very good product. Let's look at what we're cooking for our families. Thank you.
Honourable Minister, thank you very much indeed for that. I have you know, Honourable Minister, that just as there are feminist men on the panel, there are also men who cook for themselves. You don't need any woman to cook for them. Yes, well, even if it's banku and tilapia, no problem. I can do that. Wachi, anything, jollof rice, fufu. Yes, I can do it myself. Right. Okay, let's get another contribution. I'm just seeing any more female hands. Yes, right there. I think there's a couple over there. Lady there, yes.
I'm Maria May from Rwanda. I wanted to add on what was said about the initiatives we are doing here about the NCDs prevention. There is a policy about the sports for civil servants. Every Friday from 3 p.m., we go off from offices, then we go for sports. And there is a car-free zone created downtown. It was created to help Rwandans to work in town. And during some campaigns, we also do screening in that zone. And when we are doing the NCDs screening, we also do messaging on NCDs prevention. We also have a car-free day every first Sunday of each month, where from 7 a.m. to midday, we are all encouraged to go for sport. And also during that day, we also screen for NCDs and for free. And we have seen that people around Kigali, now they are really sensitized. They can go check the BP, the BMI, and sometimes we also do some messaging on prevention for cancers or any other, depending on maybe if there is specific emphasis on
Excellent.
any NCD.
All right.
And this is also going countrywide because the other cities also are taking that.
Thank you very much indeed for adding to the list of qualities that we must imbibe from Kigali. Ambassador, you're more widely traveled around this world, but particularly around Africa the most. When you look at some of the cities and countries that you visit, do you see as much of this activity as you think we need? So, for example, car-free days. Are you seeing that in, Lagos? Are you seeing car-free days in Windhoek? Are you seeing car-free days in Cairo? Are you seeing civil servants being given time off at 2 p.m. to go jogging up the main hill in Kigali to join a gym? Or are you not really seeing that kind of leadership? Because clearly it must come from the top. What are you seeing as you travel around our beautiful continent? Well, the laugh says it all, doesn't it?
Yeah, I mean, what can I say? It's not happening, clearly. There's no question that we are at a crossroads in the history of development in Africa. And that's why I think we have to take seriously what the SDGs are saying to us. And I didn't just say SDG 3, I mean the entire lot of SDGs. They are sending a very powerful message that we can transform our lives, transform our societies, transform our economies, transform everything that we have known in history and become much better, more effective, more healthier, more productive people. And I can assure you that these changes are going to come. Kigali is a lab, if you want. It's a trendsetter, if you want. But this isn't where it'll end. This is a wave that's coming all over the world. And yes, indeed, it's in the poorer the country, the more difficult it is to implement these. Although, Kigali and Rwanda would suggest that it's got nothing to do with income per se. It's got to do with political leadership, with the discipline of the citizenry. All these things contribute to this, and it's something that we can all learn from. And I think we have great lessons, but my takeaway from all of this is that we have to appreciate that the world is changing, and it's changing very fast. And Africa is going to change with it. And as I said, there'll be a lot of us here who won't believe this. But what I have witnessed in the last 15, 20 years gives me great hope that this is going to be a very different continent in the next 20 years.
Thank you very much, Ambassador. That's great. That's great. Let's get another question or query. Just looking around at hands. Yes, I know there's some men. I'll come to them last. Lady there, right in the middle. Yes. Microphone.
I don't know if this is working. Great. My name's Joanna. So the University of Rwanda has a global mental health school, summer school happening this week. And I would love to hear from the panel about experiences, lessons learned, strategies, partnerships that you've seen work on the continent around global mental health.
On mental health, did you say?
Yes.
Okay, mental health. Who wants to take that? Professor Marmot, do you want to say that? Or Professor Mbang? Professor Marmot first, and then, yeah.
There's been a view, which I think is a very naive view, that let's deal with sanitation and nutrition and shelter, and then we'll worry about what goes on in people's minds. I think that's absolutely wrong. Absolutely wrong. We need to consider people's basic needs, which include social needs for social interaction, includes dignity, empowerment, control over their lives, and we can't wait till everyone's got clean water and then say we'll worry about these other things. We have to worry about them at the same time. We know that the single biggest cause of disability adjusted life years lost globally is unipolar depression. We cannot ignore it. And that because people are in low-income countries, it doesn't mean we should set that aside. And action has to start in early childhood with good early child development. I mean, in the WHO Global Commission, we had a priority public health conditions network convened by WHO Geneva. And for depression, they said the evidence on poverty and low income was utterly convincing in relation to depression. And it starts with good early child development, with adverse child experiences, which are bad for the life of the child, with good education, and so on through the life course. And I would say we have to give parity of concern for communicable disease, for non-communicable disease, including mental illness.
Professor Mahmoud, thank you very much. Before I go to Professor Mbanya, I mean, let me throw a concept that my father raised me with growing up in Manchester, you know, where we have a lot of, it's the northwest of England and also in London, we have a lot of mental health problems. He says, this is a Western disease. You go to Africa, no, we don't have that mental health problem. The sun is shining, you have community and family, and you always get something to eat, so we don't have it. I think, Professor Mbanya, that's now out of date.
Exactly. You read my mind, because we've carried out undertaking studies in terms of depression and psychosocial aspects, especially of diabetes. The African person never accepts that because it's seen as weakness. So in that case, we need lots of advocacy in order to bring them out of the wardrobe. And then secondly, we need to be able to educate, as Professor has said, our children to grow up not feeling complex. And this would continue because of the stress of modern society, the stress of city life, the stress of joining the two pieces of the puzzle together because of poverty. So we would go into depression, but people should come out of their woods and actually declare and facilitate people to come out through advocacy and also training, especially of their young ones.
Professor, thank you very much indeed. I'm going to go to this side of the room. I may take a gentleman now, not somebody in the front. Somebody, yeah, okay, let me think. At the very back, yeah, gentleman at the back there with your, yeah, you, the one you just turned, raise your hand like this. Yeah, that man, yes, yes. So they know it's you. Very good.
Thank you. Thank you. My name is Eric. I'm a graduate and I've studied microbiology. So I have heard always talking about communicable and non-communicable diseases. And actually, in Africa, we know that many people are just affected by communicable diseases. And many of people, or they are being treated by some medicines from Europe or other countries. So I mean that in Africa, there is no much industry so that you can develop medicines and the other equipment for that can be
Eric,
used.
I'm going to have to ask you to land, as he said in Accra. Let him land. Land. What is your question?
Okay.
He has to land.
So I'm trying to ask what is the contribution, if you think the contribution of microbiologists in just solving the problem of communicable diseases in our country.
Okay, Eric, thank you very much indeed. Professor Mbanya, do you want to take that on very briefly, if you would?
Yes, I'll just take it very briefly. I think treating bacteria and conquering them is not only microbiology. It goes far beyond microbiology. But I thought he was going to ask what about the traditional pharmacopoeia in terms of integration in our healthcare system. And it's something West African countries are exploring very much, especially Benin and the rest of the people up in Ghana. I thought Ghana, that was a mistake. And then the point is, how do we integrate, be it communicable, non-communicable diseases in the same healthcare system, and how do we integrate our traditional African pharmacopoeia? most of what we are prescribing to our patients at modern medicine all came from roots and plants, and we have them in our forests, and that is a good field we have to work in.
Professor Mbanya, thank you very much. We're about to wrap up, but I want to give the last brief word to Mayor Nyamurinda, Mayor of Kigali. Now, most of the people here will be leaving in the next 24 or so hours, and they have spent all their time in this convention center and the Radisson Blu, and they haven't seen anything in Kigali, maybe apart from Kigali Heights from registration. In their last few hours, Mr. Mayor, where should they go for a healthy, sustainable experience in Kigali? Very briefly, and one that is also lawful. One that is also lawful.
Thank you, Mr. Thank you, Mr. Moderator. Actually, we have many places to go around in this city. First of all, I recommend to go to visit the car-free zone.
The cafe zone?
Car-free zone, that is a beautiful street opposite to the city hall. So that is a nice place to visit. But we have also some areas in the downtown, and we have beautiful restaurants. So just go there and you will enjoy. But just something I wanted to say.
Very briefly, please.
Very briefly is, thank you, just to say that what has been done here in Kigali as different initiatives is really possible everywhere in any other country. It's just a matter of leadership. I just quote one thing from our president, His Excellency. One time, a journalist asked him, what is his role model? And he said, my role model is my people. That is his role model. So that is very, very important. Another just quote from himself, a journalist asked him just before yesterday, the source of his courage. The source of his courage, the strength, where did he find that strength? He said, it is from the challenges and the problem I went through. So if you have been gone through challenges and a lot of problems, then you find solutions. That is, to finish, is he always like to say, just as do the best you can do and be the best you can be. Thank you so much.
Excellent. Thank you very much to Mayor Nyamurinda. And please give us a round of applause to the panel. Ambassador Kamau, Professor Mbanya, Honorable Hunsu, and Professor Mahmoud. Thank you very much indeed. That ends session 5, Old Enemies, New Threats. And we are now breaking early for lunch. Let me hand over to our MC.
Thank you so much. Thank you so much, Henry. And apologies that we have to break a little bit earlier. We'll now break for lunch, which will be served in the same areas as yesterday. Please be reminded that we have a special event on adolescent health, which will begin promptly at 2 p.m. For this special event, we will receive a very high-level keynote speaker who is the guest of honor. Please note that in order to facilitate timely security and administrative arrangements, the lunch area will be closed at 1:15. We would request that all be seated in the room by 1:30. Finally, any comments on the draft call of action should be submitted to the ushers on your way out. Bon appétit. Merci.